let's just jump right in. Karen, do you want to take it away?
Sure. So this is a kind of complex case, a lot of background. I'm going to just try to run through it quickly in the interest of time. And I'd also just like to give a little bit of a shout out to Liz Kieran, who was the fellow on this case with me and pulled some really nice pictures out for this presentation. And so this is a patient who is a 48-year-old male, didn't have a lot of medical history, and then a couple of years ago started to develop a pruritic rash diffusely in his upper and lower extremities, described as urticarial. And effectively, since then, was just a continuous itching rash. At one point, diagnosed as prurigo nodularis, atopic dermatitis. He was treated with a variety of topicals, but without much improvement. And then earlier in the beginning of this year, started to develop some skin thickening in his legs and Raynaud's in his digits. So, I, over the course of the last year, through the workup of this, I'm sorry, I think the date is wrong. He was found to have an IG kappa monoclonal component that was looked for as part of this sort of neuropathy workup. Um, Ultimately underwent a bone marrow biopsy with a 5 to 10% plasma cell neoplasm identified, but this was really just felt to be MGUS by multiple oncologists who saw him. Um, there was some consideration of daratumumab from an outside, but we weren't really able to verify that. Throughout this entire course, though, interestingly, he had elevated eosinophils, so they were really going up and down, but peaked at around 1.97 throughout this course. So because the skin manifestations were truly probably what was bothering him the most, he did undergo a skin biopsy in this past August. And this was found to have some decreased CD34 staining and elastic fibers with some dermal sclerosis that was really thought to look relatively consistent with scleroderma or systemic sclerosis, although it was noted that the number of eosinophils was a bit unusual.
Karen, I'll just jump in here. This is actually a picture from the patient's biopsy, and you can see actually there's a lot of dense bundles here. These white spaces are fat cells, and there should be a lot more of them here, and they're kind of entrapped within the fibrosis. There's also somewhat of a loss of the rete ridges over here. So there's increased collagen and sclerotic material here with reduction of the capillaries that are normally here.
Thank you. So at this point, there was concern for scleroderma, and so he was sent for more workup for that. Interestingly, he got a chest CT, which showed some possible edema, but no interstitial lung disease, and a PTE, which was suggestive of very severe pulmonary hypertension. At that point, he did establish with UW rheumatology and reported this pretty severe weight loss over the last many months, largely due to dysphagia and dysmotility type symptoms. He had a serologic workup, including ANCA, ANA, GBM, all negative, but he had a positive anti-RNA Pol3, and this is only mildly positive. I'd say 28 is considered indeterminate. It rose a little bit on a recheck, but this is a particular marker that is associated with diffuse scleroderma and specifically with renal crisis. At the time of his initial establishment of care with rheumatology, he was known to be very short of breath, and so they actually recommended that he go to the hospital for admission. And so during that admission, he had a number of diagnostics done. Interestingly, he had a PET CT and an MRA as part of his pulmonary workup and was found to have what looked to be vasculitis in his thoracic aorta and pulmonary arteries. And you can see some brightness on the imaging there. And that was confirmed to look like vasculitis on the MRA. I'll just note that's not really a typical finding in scleroderma, so a bit of an interesting abnormality for this patient. And I'm not going to go too in-depth here, but he did have a right heart cath, and I'll just draw your attention to the bottom left with his pulmonary vascular resistance of 8.74 Whitfield units. So normal is typically like less than 2. So this is very severe pulmonary hypertension. He was ultimately, during that initial mission, started on MMF with some escalating doses and prednisone, and ultimately started on transition to cyclophosphamide with these findings of the severe pulmonary hypertension. They also thought he was having potential renal crisis during this time. Nephrology wasn't actually involved at this point, but his UA had some trace proteinuria. His creatinine was relatively normal, but he was hypertensive, so they did empirically put him on lisinopril. He was discharged from that, and then a couple weeks later, readmitted for shock and was found to have pneumatosis intestinalis, which was attributed to a possible scleroderma, which can cause a hypomobility and bacterial overgrowth. So this is a known complication of scleroderma. He was managed conservatively. He generally improved. He did have an AKI, which in the setting of shock, but this actually did improve and go close to his prior baseline. The lisinopril that he had been on was held in the setting of shock. I will note he did get stress dose steroids during that shock. And you can see that the creatinine was pretty high and generally improved as he clinically improved. Then he was noted to have some mild hematologic abnormalities, so some mild thrombocytopenia and a low haptoglobin. Hematology was involved, and they did a smear, which you can see on the right there, and they saw many schistocytes. But the actual markers of hemolysis were not that high, so the LDH was only in the low to mid 200s and actually normalized on rechecks as well as the platelets. So they were suspicious that he could have a TMA, but also the actual peripheral markers were not as impressive as one might think. And then he developed an AKI to say he was restarted on lisinopril. He developed an AKI, so nephrology was consulted at that point. He was normotensive and actually got hypotensive on the lisinopril. So the team wasn't sure if there could potentially more be a hemodynamic reason for this AKI. At the time, his urine was not particularly impressive. They did a little bit more workup, which was negative, but his creatinine continued to worsen. And so ultimately he went for a kidney biopsy.
All right, thank you, Karen. So the setup is pretty good for a scleroderma renal crisis, and in the sake of time, I'll tell you that that's what we saw. But I we're showing this case because it has some really exceptional, very textbook-like pathology, and so I'll run through some of the images and characteristics that are associated with that and discuss a recent paper that's actually on the cover of Jason in the current issue of Jason as well right now. So we had a awesome sample here. It was a core of renal cortex and medulla. We had about 16 to 18 glomeruli, only one of which was globally sclerosed. You can see the gloms over here. Here's actually the one sclerotic glomerulus. And correlating with the lack of significant chronic glomerular injury, we can see that the parenchyma is also reasonably well preserved. There isn't a lot of chronic injury that has developed so far. However, when we start looking at the glomeruli, they look unusual. And so if you have a chance, you can annotate it, but I will describe what we're seeing here. So we have two glomeruli, and they're really wrinkled and shriveled up. And so we can also note that the Bowman's capsule itself is relatively preserved and intact. There isn't increased collagen accumulation over here. And both of these glomeruli look the same. So several glomeruli in this biopsy look like this. And what this is a good representation of acute glomerular ischemia. So these are ischemic changes in the glomeruli. And these are relatively acute changes in these two glomeruli because with chronic ischemia, like, hypertensive nephropathy, we may see a Bowman's capsule reaction with increased collagen and matrix accumulation around there. These glomeruli look like they haven't had a chance to really develop that. So this looks like a more acute ischemic event. You can imagine that the glomerular tuft is just shriveling up because it's not getting perfused. So here's another glomerulus that looks the opposite. Here, instead of being shriveled up, it's actually very congested, and this is all red blood cells in here. And now we can start seeing the lesions we were thinking about, that we were expecting to see. So here's probably a hilar arteriole that's feeding into this glomerulus, and you don't see the lumen. It's also actually distended open because it's stuffed with a fibrin thrombus. And so all this red material here is fibrin. You can see that the few endothelial cells look very swollen. Many of the others you can't even see. You can also see that there are darker red blood cell fragments and intact red blood cells that are trapped within this fibrin thrombus. And I'll call your attention to this area over here, where the intima and then the media are actually very indistinct. And you can see these red blood cells actually kind of pushing out into the wall of the vessel. So this is actually like fibrinoid degeneration, fibrinoid necrosis of this arteriole as a result of this, so in association with this fibrin thrombus. We also saw some fibrin thrombi within a few of the glomeruli as well. So we had kind of three patterns in the glomeruli. We had those ischemic changes. We had some glomeruli that looked congested with red blood cells, and others that had the fibrin thrombi, which looked very similar to the one here in this hilar arteriole. So here's a zoom in of that, and you can see, the breakdown of the vessel wall with extravasation of the red blood cells out into the media, into the wall. So the not only is the vessel occluded, but actually because of the pressure and the injury process, it's actually degenerating and you're pushing material out into the wall. So this is now a trichrome stain of a few other arterioles, kind of showing the same thing. The previous one was kind of a longitudinal section. These are kind of cross sections of the arterioles. And again, you don't see a lumen at all because here are some endothelial cells that are kind of swollen. And here's the muscular wall. And instead, you have a marked expansion of that intimal area. You have extravasation of these red blood cell fragments into the intima and even into the media over here. And so all three of these vessels are showing some degree of that fibrinoid necrosis and degeneration of the vascular wall. So now here's a small artery, probably an interlobular sized artery, even a little larger. And again, now you can see another feature of an acute endothelial cell injury. This is known as myxoid or mucoid degeneration of the intima. So again, the lumen is actually probably right here. And so you can see a little white space over here. So it's cinched down all the way down from here. And then so remember that the resistive index of the vessel is going to go vary as the fourth power of the diameter. So this is a marked reduction of the diameter and marked increase in the putative resistance as well. So all of this is like edematous material and loose matrix, some entrapped in inflammatory cells. And then these things, if you look at a higher power, are again those red blood cell fragments that have kind of found their way and been pushed into that edematous intima of the artery. So if you hear about mucoid degeneration or myxoid degeneration of the vessel, this is what we're talking about. So the paper that I'll discuss shows a lot of trichrome stains, and so this is what it actually looks like. Again, you can see that loose edematous material in the intima, and again, this is the lumen, the residual lumen that is left behind, which is markedly decreased compared to the native diameter of that same vessel. So on H&E stains, this is again that same vessel. It's called mucoid or myxoid because it has this kind of bluish like tinge to it. And so this is a helpful feature for us to actually identify it. And again, you can see these extravasated RBC fragments. In addition to those acute changes that we were seeing, so remember the acute changes we saw were fibrin thrombi within the arterioles and the glomeruli. We saw fibrinoid necrosis, fibrinoid degeneration of the vessel walls. We saw mucoid or myxoid degeneration of arterial vessels with entrapment of RBC fragments. And now here we're seeing kind of a subacute or acute to chronic type change, which is where you can see that the edema, the intima has been expanded, but it's not just loose material. It's actually where it's laying down layers of matrix as well. And so this is kind of a subacute change, and you can see exactly why it's called an onion skinning change here. You can see these additional layers that are being set up within this subacutely injured small artery. So the immunofluorescence was essentially negative. What I'm showing you here is the fibrin stain. And again, it's highlighting the injury and the accumulation of fibrin thrombi within vessels. In this particular field, we didn't see any thrombi within the glomerulus over here, and there were no immune deposits. Finally, EM, there were again no immune deposits, but we were seeing that acute ischemic change in the glomeruli. So here again are the basement membranes. They're all wrinkled and corrugated. Again, it's like the whole glomerulus has kind of collapsed in an ischemic fashion. There was a fair amount of podocyte foot process effacement overlying these capillary loops. And here you can see an acute endothelial injury process as well, where you have subendothelial expansion with this electron-lucent material, probably trapped serum in that subendothelial space. So the diagnosis, which is probably no surprise here, was thrombotic microangiopathy. It's predominantly showing acute features, though that onion skinning is showing that there is some chronicity to this as well. There wasn't a lot of chronic glomerular or parenchymal injury at this point. There was also some degree of acute tubular injury, no surprise, since the parenchyma wasn't getting perfused. And so pretty much all the vessels we saw had some degree of acute endothelial injury. So we had the intimal swelling, entrapment of red blood cells, the myxoid or mucoid degeneration, fibrin thrombi both within the glomeruli and arterioles, acute ischemic collapse of some of the glomeruli, and also development of some onion skinning-like changes. So of course, these changes are non-specific when we say TMA. It can be seen in a whole range of things. But of course, this patient has scleroderma, so that's clearly where we're going to pin the blame on and associated with that process. So let's discuss quickly this recent study, which is literally on the cover. So you can see here's that trichrome-like stain. You can see it's very similar to what we saw in this patient. And this is actually showing some onion skinning, which we also saw in this patient. So there have been a few studies over the years. There've been, this is not a common entity. It's fairly rare. So some of the previous studies have usually been single center studies with about 15 to 20 patients. This was a much larger study in the context of this disease. They were able to identify about 65 patients who had some follow-up. And these patients were kind of collected over the course of, I think, 2006 or 2004 to 2020, so 15 plus year period. And many of these patients progressed to kidney failure with a median follow-up of 2 years. So this is a bad development in the context of scleroderma. They found the various different clinical presentations of scleroderma, whether it was diffuse or limited, or the so-called sign scleroderma, which is sparing the skin but has internal organ fibrosis. And interestingly, they found that the injury patterns were not defined by the clinical presentation of scleroderma. So all three of these types of scleroderma could have any of the types of vascular injury processes that we'll discuss. Okay. So systemic TMA, and there's some question about whether this patient also had some systemic TMA, was again present in 62% of the patients. And these patients tended to have a more aggressive presentation and they demonstrated acute arterial injury, myxoid changes, and acute tubular injury on the biopsy. And then they were also able to correlate some clinical and histologic parameters with the risk of developing kidney failure. And so they found that creatinine greater than 4.4 at presentation, the acute arteriolar TMA, which we saw in this patient, and the development of onion skinning, which we also saw in this patient, were independently associated with the risk of kidney failure. Now, this patient didn't have quite this high of a creatinine. I think it was 1.8 around the time of biopsy. And so maybe didn't check this box, but definitely had a lot of the other histologic features that were associated with bad prognosis. So so this study did a couple of interesting things. They were able to actually quantify some of these injury signatures, injury features in the biopsy, and then create like a little heat map to kind of understand whether there were particular types of injury patterns that tended to cluster together. And they found essentially what looked like three different groups of pathologic kidney injury. There was one group which tended to have more chronic injury with IFTA, hyalinosis, and glomerular sclerosis. This was cluster one. And then these other two clusters had, the glomerular thrombi, thrombotic microangiopathy, and all those other acute changes that I described to you as well before. So cluster two and cluster three were a little bit more acute. So again, just to remind you, in this patient, we saw all of these highlighted injury processes. So probably mostly in this cluster three, with even some features of cluster two as well for this particular patient. Now, interestingly, they found that even though the cluster one had more chronic injury, it was these patients in cluster two and three that had poor kidney outcome and actually also poor overall overall survival as well. So it was kind of interesting to think of that the chronic injury patterns were associated with better prognosis, which is kind of counter to the usual things that we think about in IgA nephropathy and other glomerular disease processes. But I think what we're seeing here is that those patients with chronic injury really don't have the much worse acute injury processes, which are ultimately going to dictate kidney outcome and patient survival as well. So they also looked at the classical pathway of activation of complement. They found that there was some evidence, and this has been seen in other studies as well, that there's more of a classical pathway activation rather than alternative pathway. And they were even able to, using a proximity ligation assay with the C2 and C4 components of the classical pathway convertase, they were able to actually see the assembly of that convertase in the injured vessels. But they said it was more classical rather than the alternative pathway that was being activated in these patients. Okay, so I'll turn it back to Karen for a quick follow-up.
Thanks, Rob. So after these findings, this patient was started on captopril and uptitrated. I will note I saw a question from Catherine in the chat about his blood pressure. So he had been normotensive initially, which is a known entity in scleroderma renal crisis. It's just uncommon. So about 5 to 10% of patients will not necessarily be hypertensive, but certainly rarer. The captopril was uptitrated, and I think you could say that he actually started to develop hypertension through this because his blood pressures rose somewhat over the course of the captopril uptitration, more to the 130s, even with higher doses. Unfortunately, his kidney function continued to worsen quite rapidly. We actually gave him a dose of eculizumab based on some of these data about complement activation and essentially feeling like there weren't a lot of other options for him. There's not strong data for the use of eculizumab in scleroderma renal crisis as of now, but there are a number of case reports that have shown efficacy in some patients. So we were able to get him a dose of that. Also note that he had a repeat bone marrow biopsy because there's all along been this question of whether the MGUS could somehow be related. There are enough atypical features of this patient writ large. The plasma cell neoplasm was somewhat more prominent in the biopsy, but oncology wasn't particularly impressed by this. He ultimately received a dose of obinutuzumab per rheumatology. So rituximab is commonly used in scleroderma, but because he had gotten eculizumab, they thought that the OB might be more effective. And ultimately, a modified ham test, which was sent prior to the eculizumab, did come back and was actually normal, and so eculizumab was not continued. Unfortunately, he really just continued to progress with his kidney failure and was started on dialysis about a week later. I'll just note this was the trend of his creatinine. You can see when dialysis was started there, but it was pretty severe. Basically, it was just going up by 1 a day. I thought kind of interestingly, and I don't know if these are true and unrelated, but the eculizumab, afterwards, he had this mild thrombocytopenia, which did somewhat improve a few days later. He had also gotten Cytoxan early in his course and prednisone. There's other treatments happening for this patient. It's a little hard to parse things out, but I did think that was somewhat interesting. And I think at this point, the patient remains dialysis dependent hospital. So unfortunately, pretty severe systemic illness and very severe kidney disease.
Yes, thank you, Karen. So again, like the histologic parameters on that paper that we just discussed as well would have predicted that this patient is going to have, the bad course as well. And so in the sake of time, I would please put your questions in the chat. We'll try to address them. I want to give Dr. Patel and the team as well some time to present the second case. Thank you, Karen.
All right, thank you. Am I sharing the right screen? Does that look right?
Looks good.
Okay, thanks. All right, so we'll go ahead and get on to our second case. I'm very happy to have Dr. Yuhong Ng as our clinical discussant for this case. So Yuhong, if you want to go ahead with the clinical history.
Okay. And Anan, I assume who's advancing the slide? You
Oh,
are,
I
right?
am, sorry.
Okay,
Yeah.
alrighty. Just double checking. So this is a 30-year-old gentleman, past history secondary to MPGN, immune mediated, who's treated with steroids and MMF in the past, who underwent a deceased donor kidney transplant back in June of 2020. Just a little bit about his transplant history. Because he's so young, he got a very good kidney with a KDPI of 13. He was induced with ATG. The only complication he had was he had some delayed graft function requiring a few sessions of dialysis, but his kidney function subsequently recovered, and he did really well after transplant. Next slide, please. So post-transplant, like I said, he did very well. Within the first year of transplant, his creatinine native at around 1.3 to 1.5. All the surveillance markers, DSAs, cell-free DNAs, BKs were all negative. Unfortunately, once the patient was sent back to his primary nephrologist, there were concerns of him not coming for lab tests and also not attending clinic appointments. So at his 2-year follow-up with us, he was noted to have a slightly elevated creatinine at 1.65, perhaps a slightly increased UPCR. Usually it's pretty undetectable, but it did go up to 0.4. And as part of his 2-year surveillance, we did a donor-specific antibody on him, and from no detectable donor antibodies, he was found to have 2 new donor antibodies. One was a DR53 at 23,000 MFI, and the other was a DQ08 at 11,000 MFI. So with this slight change in his creatinine with a new donor-specific antibody, and what I didn't show you is he also had a high AlloSure at 2.8. We did the first kidney biopsy on him, which, Anand, I don't think you're showing this one, right?
Right.
Yeah, okay. So this first kidney biopsy showed acute cellular rejection, but he also had features of antibody-mediated rejection with peritubular capillaritis, focal glomerulitis, positive C4D, and had some medullary angiitis and thrombotic occlusions of the medullary vessels as well, but very mild chronicity. So with this first biopsy finding, with a mixed cellular rejection and antibody-mediated rejection component, for the cellular rejection, we treated him with salumedrol at 500 milligrams, 3 doses. But for the ABMR, we treated him with IVIG and rituximab. And the initial plan was to treat him for 6 months. And what you can see here is his antibody levels actually responded really well to this treatment. So we started it in August of 2022. And what you will notice is the donor-specific antibody MFIs improve fairly dramatically. This was consistent with the AlloSure levels that also improved. And because he did so well with this, I decided to extend him and give him another 6 months course of it. But interestingly, with the second course, he didn't actually improve anymore. In fact, his DNA, his donor-specific antibodies started going back up, and his cell-free DNA level initially improved, but then did not continue to trend down and was really fluctuating between 1.8 to 2.2. So we decided to repeat a kidney biopsy, a second kidney biopsy after he got his second course of rituximab and IVIG.
Yep.
So.
All right, thank you, Johan. So this biopsy is actually a biopsy I saw as a fellow with Dr. Alpers. And before I show you the biopsy, I think I find it helpful in a transplant to think about a broad differential diagnosis. So I think often my first thought and the first concern is for rejection, which can be T-cell mediated or antibody mediated. And in this patient's first biopsy, we saw evidence of both of those. But it's important to consider other complications that can occur in an allograft, including treatment complications such as infection, as Dr. Watford told us about with BK nephropathy, as well as calcineurin inhibitor toxicity. Various surgical complications. There can be recurrence of original disease, depending on what that original disease was, and also develop de novo disease. So let's take a look at this second biopsy. we got a really nice sample, 2 cores, mostly renal cortex with just a little bit of medulla on the end here. We had a sample of up to 25 glomeruli per level, and the chronic injury is still maybe a little bit more than that first biopsy, but overall fairly mild. We're seeing at low power that these tubules are pretty much back to back, so not a lot of chronic injury, just a little bit here. And we're also seeing at this low power that there's not much edema or inflammation spacing apart the tubules, so much lower concern for T cell mediated rejection, or at least we're not seeing a lot of T cell mediated rejection at this low power. So I'm going to start with the tubules and interstitium, and then we'll spend more time looking at the glomeruli and other vessels. So for T cell mediated rejection, we're looking mainly for T cell inflammation that infiltrates into the tubules and interstitium. And I'm showing a few fields of view on a PAS stain where we can see that these tubules are pretty nearly back to back. There's a little bit of inflammation here, which is fairly mild. And I'll blow up one of these tubules a little bit bigger. And we can see, and if I make that a little even bigger, there's a few lymphocytes which are infiltrating into the tubular basement membranes. So these lymphocytes have a darker chromatin in their nuclei compared to these tubular epithelial cells. So there is some tubulitis that we're seeing, as well as some interstitial inflammation, but this is overall fairly mild. So this could be consistent with some level of T cell mediated rejection, but again, pretty mild, not likely to be the major explanation for this patient's elevated creatinine. So we'll next go to the glomeruli, where I'll spend more time. And so this patient has a history of elevated donor-specific antibodies, has plenty of clinical concern for antibody-mediated rejection. And for antibody-mediated rejection, what we're looking for by light microscopy is evidence of microvascular inflammation, which looks like an influx of leukocytes in the glomerular capillaries and the peritubular capillaries. So we can see even at these kind of medium power image, I'm going to focus on the glomeruli, but for now, but we're catching some of these peritubular capillaries that are distended with some lymphocytes. But in these glomerular capillaries, we can see quite a few lymphocytes within the glomerular capillaries. And they're not hard to spot, but ideally, if we follow the Banff criteria very strictly, to call it glomerulitis, we want to see not just an influx of leukocytes, but also a reaction of the endothelium, so endothelial cell swelling. And that is not very prominent here. There's maybe a few instances of swollen endothelial cells, but the overall, although there's quite a bit of influx of leukocytes, the number of glomeruli that had overt glomerulitis with endothelial cell swelling was relatively focal. And in this glomerulus, I'm also showing you some segmental sclerosis. So here's a portion of that glomerulus that's filled in, whereas there are many other loops here that are patent. So the features of microvascular inflammation are not that bad in the glomeruli, but if we go to the peritubular capillaries, they are diffusely dilated, and we can find some instances of fairly severe peritubular capillaritis, where there are quite a few lymphocytes within these capillary lumina. So we have features of microvascular inflammation by light microscopy. I'll now go to the immunofluorescence, and here's C4D, and this is the staining is very dim, but we saw positive diffuse staining throughout most of the peritubular capillaries. And for our evaluation of antibody-mediated rejection, it's really the how widespread the staining is rather than how strongly positive it is that matters. So this diffuse staining is considered positive despite the weak intensity. And now putting everything together, we have good evidence of antibody-mediated rejection. So we think about 3 criteria. There's the donor-specific antibody that was detected in the serum. Here we have evidence that that antibody is activating complement, and then we have evidence that that complement activation is resulting in inflammation in the vessels. So this so far looks very good for antibody-mediated rejection. But as I mentioned earlier, we want to keep a broad differential diagnosis, and these features of inflammation are suggestive of antibody-mediated rejection, but no one finding in isolation is completely specific on its own. And so looking at the rest of the immunofluorescence, and we actually see quite a bit of immune complex deposition for these other immune reactants. So there's strong IgG, there's a little bit of IgM, there's a fair amount of C3, and there's really strong C1q. So we have evidence of immune complex deposition in the glomeruli, and this complicates our interpretation because immune complex deposition provides another potential explanation for microvascular inflammation. But this would primarily be in the glomerular capillaries, would not explain the peritubular capillaritis. So I'll just briefly show you the electron microscopy for this case. I just have one image to point out. And to orient you, it helps to find the lumina of these glomerular capillaries. Sometimes we get lucky and find a red blood cell that helps us be more confident in how we've oriented it. So we have three capillary loops here. In between, holding it together is the mesangium. And then we're seeing, so here's the nucleus of a mesangial cell. And what we're seeing right up against the mesangial cells are these discrete electron-dense immune deposits. So we have some mesangial deposits, and then over here we have a deposit as well. So there's the glomerular basement membrane. There's podocytes on the outside, endothelium on the inside, and this deposit is sandwiched in between the glomerular basement membrane and the endothelium. So we have a subendothelial deposit. And there's a few subepithelial deposits, maybe one here, but we're mostly seeing mesangial and subendothelial immune deposits. So to put all of this together, what we saw in this biopsy is an immune complex mediated glomerulonephritis based on those IF and EM findings. It's likely recurrent, given that the patient's original disease was an immune complex mediated MPGN. Although we didn't have all the details about the original disease. We also saw features of antibody-mediated rejection. And as I said, the glomerulitis is difficult to interpret because that could be due to either the immune complex or antibody-mediated rejection. But the C4 staining and the inflammation in the peritubular capillaries, we can be more confident in attributing to antibody-mediated rejection. And then there was just focal tubulointerstitial nephritis, which could be consistent with T-cell mediated rejection, although it's below the threshold set by Banff criteria. Okay, so I will pass it over to Johan to tell us what happened next.
So with the findings of his second biopsy, with the possibility of both a recurrence of his MPGN, as well as an antibody-mediated rejection, we decided that we would trial a B-cell targeted therapy. One thing I forgot to add, with that finding that he had recurrent MPGN, we also repeated a vasculitis screen, monoclonal antibody screen for him, and all of it came back negative, which was consistent with what happened to him before the transplant. And so the decision was, what we would do for him. And this is a patient who's actually already gotten rituximab and IVIG for a year when this happened. So we didn't think that continuing to give him rituximab would be helpful. So we decided to trial a plasma cell-based therapy with daratumumab. So we put the patient on daratumumab for 6 months. And the third kidney biopsy was to see what happened to him with the daratumumab.
All right, so let's take a look at this third biopsy. This is one that I saw subsequently as an attending, and we got 2 cores of cortex. I'm showing just one of them in this image here, and we're at this low power seeing that there's a good sample, about 14 glomeruli, and not a lot of progression of chronic injury, fortunately. So well, look, again, I'll go briefly in the tubules and interstitium and then focus on the glomeruli. And in this case, there was some very focal interstitial inflammation, overall less than 10% of the total preserved cortex, and didn't really see any tubulitis. So now not much evidence to support T-cell mediated rejection. And we'll focus on the glomeruli where there was the history of both MPGN and antibody-mediated rejection. And so in this first glomerulus I'm showing you, we're not seeing that influx of leukocytes in the glomeruli. So there's not really evidence of ongoing activity at this point, but there is some expansion of the mesangial regions and maybe some thickening and remodeling of the basement membranes. So I'll show you a few other glomeruli, and I'm going to switch over to the Jones stain, which highlights some of these changes a little more clearly. Some of the glomeruli, like this one in the upper left, look pretty close to normal. There's a little hint of some increased pink or eosinophilic material. This glomerulus, you can maybe see a little bit more eosinophilic material in these glomerular capillaries. And I think this bottom left one shows the most prominent, these big accumulations of eosinophilic material in the glomerular capillary walls. And I'll make this a little bigger where we can see that. And we can also see many segments where the basement membrane is duplicated around this eosinophilic material. Okay, so I'm going to spend a few minutes telling you about how I think about basement membrane duplication. I'll skip over the question and point out that we can see basement membrane duplication in many different conditions. And that includes this patient's original disease of MPGN, as well as chronic antibody-mediated rejection. So let's talk a little bit more about why the basement membranes duplicate. So I think it's really helpful to remember that the basement membrane is being built and maintained by both the podocytes and the endothelial cell. So the basement membrane will duplicate if something gets in the way of either the podocyte or the endothelium in its attachment to the GBM. So if either cell gets detached from the basement membrane, it'll continue to secrete matrix and produce a new duplicated basement membrane. So in an immune complex mediated process like membranous nephropathy, where you have subepithelial deposits, or MPGN, where you have predominantly subendothelial deposits, in either case, the deposit is getting in between the cell and the basement membrane. And over time, that cell is going to secrete more matrix and result in a double contour of the basement membrane. But we can also see this phenomenon in chronic endothelial injury from TMA or transplant glomerulopathy when that endothelial injury is due to antibody-mediated rejection. So in the prior biopsy that Ram showed, we saw a nice example by electron microscopy of those trapped serum proteins that get underneath the injured endothelium. And that's another mechanism by which the endothelium can be detached from the basement membrane. And if that injury persists over time, then the basement membrane can duplicate for that reason as well. So, so in this case, again, we have a history of both MPGN and antibody-mediated rejection, two potential mechanisms for those basement membranes to become duplicated. So, so to distinguish between these possibilities, we'll look at the immunofluorescence and electron microscopy. The immunofluorescence, I'm showing just the C1q, which where we can still see continued strong deposition in the glomeruli. The other immune reactants, the glomeruli didn't show up as well in those sections, but we did see some staining for immunoglobulin as well. And the C4d in this biopsy was negative. So I'll show a few examples of the electron microscopy images. We're seeing a few capillary loops here. There's a couple loops that look close to normal and some loops like this one where we see these large accumulations of electron-dense deposits. And if we look a little closer here, we can see some deposits like this that are smushed right up against the podocytes, and many deposits that are intramembranous, so they're within the basement membrane, and there's presumably because they were either subendothelial or subepithelial, and now the basement membrane has remodeled and duplicated around those deposits. And here's another field of view. We're seeing some mesangial deposits here, and we're seeing a capillary loop here that has no deposits and also has no duplication of the basement membrane and a segment over here as well. So based on these findings, we're seeing most of the basement membrane duplication occurring around immune deposits. It suggests that the changes that we're seeing in this biopsy are because of the recurrent MPGN rather than transplant glomerulopathy. So we're in these segments that do not have deposits, we're not seeing duplication, and we're also not seeing much of that electron-lucent material that would be associated with an endothelial injury due to transplant glomerulopathy. Okay, so to summarize what we found in this biopsy, we see continued evidence of that immune complex glomerulonephritis, and we see basement membrane remodeling, which based on what we see is most likely secondary to the nephritis, although I can't completely exclude the possibility that there's some transplant glomerulopathy as well from his history of antibody-mediated rejection. So these were the main findings, and then there's just a little bit of chronic injury in the background. So the two main takeaways I hope you can take from this case. One is just that the histologic features of rejection on their own are not entirely specific, and it's really important for us to think about all of the different mechanisms that can cause that inflammation to make sure we don't miss something other than rejection that can cause inflammation in the allograft. And then the other point was to discuss the causes of this basement membrane remodeling, which is the result of any ongoing endothelial injury or immune complex deposition in the capillary loops. So I will stop there. We have a couple other minutes. Johan, I don't know if you have any follow-up since this biopsy was done. I know it wasn't all that long ago. Otherwise, we can stop there. And if there's any questions, we can, let me see. Right. Looks like my computer is lagging for a bit, but
Thank you
Yep.
for that really interesting case. And there are a few questions and comments in the chat. There's a question from Daryl. Did this patient have a complement workup for recurrent immune complex C3G?
I assume the question is targeted at me.
Oh, yeah,
Oh,
yeah,
yeah.
I assumed. Sorry.
So his complements level have always been normal. I didn't send off the complement studies. Um, he's always behaved much more as an immune complex, even with the first even before his transplant. Um, I have not usually sent off the alternative pathway complement studies on him. I certainly could. That's not my experience. I don't know if others usually do that.
And
Yeah,
this,
this is
go ahead, sorry. Yep.
yeah, this is Daryl. I mean, there's various levels. I think, I mean, this is a much more common, I think, pediatric disease that we see. Fortunately, not often of recurrent C3G, but it does happen. I think a soluble C5b9 could tell you if there's a targetable pathway, but now with new complement drugs like iptacopan or pegcetacoplan, I think that since seems to be a pretty problematic case, that might be treatment options that would be available.
I'm happy to send it off.
And then just a couple other questions in the chat. Also for you, Yuharn, did your treatment change based on the third biopsy? And from Nikolai, was C3 immunofluorescence positive in the last biopsy? For maybe Anand or Yuharn.
yeah, so for my part is fast. I'm pretty sure C3 was positive. It was positive in the biopsy number 2. In biopsy number 3, the glomerulus didn't show up that well in that section, but it looked like it was probably weakly positive.
And the Saida's question, he actually responded really well to the daratumumab the first time around, but I stopped it, and then he kind of got worse, a little bit worse. So with that biopsy finding, I restarted him on daratumumab, so he just restarted on it. Not sure if anyone would use other kinds of treatment. The reason why I've chosen Dara over rituximab was because all this happened after 1 year of rituximab treatment.
And was it true that those deposits or duplication of the GBMs was significantly progressed from the second to the third biopsy?
Yeah, so I think the extent of depth of immune deposits wasn't that different between the two biopsies, but the extent of basement membrane remodeling was a big change between those two biopsies. There was not much basement membrane duplication in the second biopsy, but there was it was very prominent in the third biopsy in most of the glomeruli.
Yeah. I mean, I agree with Daryl. This will argue more towards a more C3 deposition type of injury in addition to the complement mediated injury. So yeah, Johan, maybe the suggestion for iptacopan is not it's not necessarily bad, especially if daratumumab doesn't look like it's making more improvement.
All right. Well, thank you, everyone. We're at 9:30, and so coming to the end, unless there are any kind of last burning questions or comments. Thank you for the interesting cases this morning, and we will have just a plug for next week. We're going to have our first visiting professor for the academic year in Sandeep Malapadu, who's coming from Stony Brook University. So we'll have an in-person grand rounds next week. So look forward to seeing all of you in person at SLU. With that, have a wonderful weekend. Stay dry, and I'll see you guys next week.